Welcome, everybody. It is my pleasure to introduce the global grand rounds on advanced techniques in endoscopic sinus surgery. This is the first time we're having live cadaver dissection with the lectures. It is co-sponsored with Pan American Association of Otolaryngology and Head and Neck Surgery. And we also have Medtronic as a sponsor of the cadaver dissection. So my name is Maria Serna. I'm an international coordinator for the international affairs for the American Academy of Otolaryngology. And it's wonderful to see so many participants registering and joining us live. And I really want to thank all of the panelists and moderators and American Academy for working on this global grand rounds. So we have probably probably now over 2,600 attendees that have registered, and from 123 countries, which is fantastic. As you can see in the chat, people are coming from all over the world. Again, just demonstrating how important it is for us to work on global educational initiatives together. We also just recently rejoined the International Federation of Otolaryngology Society, IFOS, and we're honored to be a part of the global community. So once again, I really want to thank our program sponsor, Medtronic, for providing the lab and cadaver dissection experience for this event. With that, I would like to introduce the CEO of the American Academy of Otolaryngology and Head and Neck Surgery, Dr. Rahul Shah, to say a few words.
Thank you so much, Dr. Serna, and thank you for putting this together. I have a few announcements, but first, huge thank you to the Pan American Association of Otorhinolaryngology Head and Neck Surgery for being our collaborators for this global grand rounds. Thank you very much. Excited to announce that Medtronic is our sponsor today, broadcasting from their global headquarters in Jacksonville, Florida, which I had the pleasure of visiting. Huge thank you to Drs. Hahn and Dr. Levine, who will be utilizing the IPC, the M5 microdebrider, the 30,000 burrs with the Stealth Station navigation system, where they will show us with sub-millimeter accuracy how great the products are. Medtronic also has drug-eluting stents with the Propel and Sinuva product lines. Thank you very much to Medtronic. Today we're focusing on rhinology, but we all know they have market-leading devices for intraoperative nerve monitoring, the NIM Vital, and the parathyroid eye. I visited their facilities a few months ago, and I was blown away by their commitment to quality and innovation. So thank you, Medtronic. We also want to announce that we have our international membership education bundle. At the Academy, we believe education should be for all. We're thrilled when you join the American Academy of Otolaryngology. There are educational modules that are now part of your membership. We appreciate you joining us. My final announcement, Dr. Serna, is the American Academy of Otolaryngology is thrilled to come back as a dues-paying member of IFOS, the International Federation of ORL Societies. They've been very gracious and partners with us, but now we also are going to join the 50,000 otolaryngologists from 120 countries representing the global voice of otolaryngology. So thrilled for that announcement. I'm going to pass to Dr. Alvarado, who's the president of the Pan American Society, to say a few words. Dr. Alvarado, thank you very much for the collaboration, please.
Oh, thank you. It's my pleasure. Thank you, Dr. Shah and Dr. Maria Serna, for your kind introduction. The Pan American Association greatly values the teamwork between our organization and the American Academy of Otolaryngology. A special thanks to Dr. Troy Goodard, Academy President, Dr. Maria Serna, Coordinator for International Affairs, and your Dr. Rahul Shah, EVP and CEO of the Academy, for their unwavering support and partnership. It's an honor for the Pan American Association of Otolaryngology Head and Neck Surgery to participate in this joint virtual grand round hosted by the American Academy of Otolaryngology. This event showcases the incredible collaboration between our societies, boosting our shared mission to advance education. Kudos to Dr. Pablo Stolovitsky and Dr. Jolie Crespo for assembling a fantastic panel that celebrates diversity and inclusion, and a heartfelt thanks to our Academy staff, Katie Grimes-Stauf, Elin Swinghart, and Enzo Graniello for their hard work and dedication to our global community. Looking ahead, we're thrilled to invite everyone to the Pan American Congress in Santiago, Chile from November 11 to 14, 2025. This joint meeting with the Academy is set to drive meaningful advancement in our specialty and strengthen our collective impact. Together, let's continue to foster collaboration and innovation, ensuring the future of otolaryngology remains as bright as the passion and dedication of our oral community. Thank you.
Thank you, Dr. Alvarado. I would like to move forward to introduce our panelists for the Global Grand Rounds. Dr. Pablo Stalovitsky has been national, international leader in the American Academy. He's very highly regarded and recognized otolaryngologist and in the field of rhinology specifically. He's a CEO and co-founder of ENT of Georgia North. He had multiple leadership positions within the Academy of Otolaryngology and Head and Neck Surgery. He's been serving on the board of directors and has also been a prior international coordinator for the Academy. He's one of the main initiatives, has been introduction of the Global Grand Rounds during his term as a coordinator. And this initiative has grown, and now we're all benefiting from it. So Pablo, thank you so much for this wonderful initiative, and again, during the pandemic, which has grown to like a big event and very influential event. He is also Secretary General of the Pan American Association of Otolaryngology and Head and Neck Surgery, and presidents in both Georgia Society and Metro Atlanta Society of Otolaryngology Head and Neck Surgery. I would also like to introduce Dr. Julie Crespo, who's from Panama and is a third generation of otolaryngologists. So she's from family of otolaryngologists. Her areas of expertise include rhinology and skull-based surgery, as well as sleep surgery. So she currently works in the hospital Paitia and the Crespo Clinic in Panama City, and has participated in research studies in both Panama and United States. She serves as a treasurer of the Ibero-American Society of Sleep Surgery and belongs to American Academy of Rhinology and the International Society of Sleep Surgery, and also Panamanian Society of Otolaryngology. So Dr. Stalovitsky and Dr. Crespo, thank you for leading this Global Grand Rounds, and please.
Thank you.
Thank you, Dr. Maria Surna, for your kind introduction and for your unwavering dedication to advancing global otolaryngology. Well, we're in for a real treat today with an incredibly exciting and insightful session ahead of us. This edition of the Rhinology Global Grand Rounds shines the spotlight on advanced techniques in endoscopic sinus surgery. Co-hosted with the Pan American Association of Otorhinolaryngology, this webinar promises a lineup of exceptional content, including live dissections, demonstrations, and expert panel discussion. With nearly 2,600 participants joining from 123 countries, this webinar truly reflects the global commitment to enhancing education, sharing knowledge, and improving patient care. Special thanks to Medtronic for sponsoring this event and for making their lab available for the live dissection feature in this series. Attendees can look forward to procedures like endoscopic medial maxillectomy, septoplasty, dacrocystorhinostomy, orbital decompression, sphenopalatal ligation, and advanced frontal sinus techniques. This is an exciting first for the Rhinology Global Grand Rounds. And a very special thanks to our Academy staff, Katie Grimes-Stauss and Liz Swinehart, for their hard work and dedication. We could not have done it without them. And now it is my privilege to introduce the esteemed faculty for the 2025 Rhinology Global Grand Rounds. Professor Dame Valerie Lund is a distinguished authority in rhinology, serving as Professor Emeritus at the Ear Institute, University College London, and Honorary Consultant ENT Surgeon at the Royal National ENT Hospital. She's been a trailblazer in endoscopic sinus surgery since the 1980s, pushing boundaries and refining techniques. Over the years, she's held prestigious positions like the co-chair of EPOS, editor of Rhinology, and president of ENT UK, earning her worldwide recognition. She was appointed Commander of the British Empire by Queen Elizabeth II in 2008, and most recently, she was knighted in the 2024 King's New Year honors, receiving the title of Dame Commander. Professor Lund is going to present on evolution of endoscopic sinus surgery. Professor P.J. Wormald, a renowned figure in rhinology, holds a dual professorship at the University of Adelaide in Otorhinolaryngology and neck surgery and skull-base surgery. Known worldwide for his expertise in sinonasal disorders, endoscopic sinus surgery, and skull-base surgery, he's published 10 books, 48 chapters, and over 550 articles. His work focused on pathophysiology of chronic rhinosinusitis, advancements in frontal sinus surgery, wound healing following sinus procedures, and innovations in endoscopic skull-base surgery. His groundbreaking work has redefined the field, securing his legacy as a trailblazer in sinus and skull-base surgery. Professor Wormald is going to present on complex frontal sinus surgery. Dr. Rodolfo Nazzar is a professor at the Department of Otolaryngology at the University of Chile. Known for his work in tertiary rhinology and endoscopic skull-base surgery, he's made strides in surgical techniques and education leading to fellowship programs in rhinology and skull-base surgery. As such, he set up a cutting-edge sinonasal endoscopic lab for ENT residents and designed hands-on postgraduate courses. Recently, he was named president of the 39th Pan American Otorhinolaryngology Congress, taking place in Santiago, Chile in November 2025, as Dr. Jacqueline Alvarado announced. His contributions continue to advance rhinology and skull-base surgery across the region. Dr. Nazzar will present on extended access in endonasal surgery. And now I am honored to invite Professor Dame Valerie Lund to share her insights and guide us through the fascinating journey of the evolution of endoscopic sinus surgery. Professor Lund.
Well, thank you. And thank you very much for your kind introduction. And just let me say how deeply honored and thrilled I am to be part of and also kicking off this exciting grand round. Well, most of you won't remember who are listening to this and seeing this broadcast, but back in the mists of time, when I was a medical student, the instruments for taking nasal polyps out were snares, and they'd been around since the Middle Ages. The way to drain the maxillary sinus was from the front through a caudal luck or an inferior meatal antrostomy. But as I was starting my training, it was quite clear that these operations did not work well. My postgraduate thesis looked at inferior meatal antrostomy and showed that not only did it not work, but it actually made patients often worse with postnasal discharge. We didn't dare attempt the ethmoids through the nose for fear of damaging the eye, and operating on the frontoethmoid region was usually external, using operations from the late 19th and early 20th century. But they were bedeviled by problems such as medialization of the orbit, which would close off the drainage, by diplopia due to underaction of the superior oblique muscle, and cosmetic issues. So these operations were not without their problems. So I was extremely fortunate to start my training in ENT at the point when endoscopic sinus surgery started to come in. Now, of course, part of this, in fact, much of it was driven by technology, notably the emergence of the modern endoscope, invented by Harold Hopkins from the University of Reading in the UK. And his use of the solid rod lens system provided a much better image, a brighter image, a wider viewing angle, much better visualization, which of course has evolved into the 3D and multi-directional endoscopes that we use today in conjunction with our wonderful high-resolution cameras. It's hard to imagine that we relied upon plain X-rays and hypercycloidal tomography. But of course, in the 1970s, we see the advent of CT scanning and MRI, and now we can simply send our patients for a few moments to get a portable office CT cone beam. That has now become a standard of care, intraoperative imaging and navigation. And the improved visualization and instrumentation clearly were important features in driving forward our interest in endoscopic approaches. The frontal sinus then became endoscopically available. Wolfgang Draff developed his own system for approaching this area, and you'll hear from Professor Wormald his own approach and ideas regarding his approach to the frontal sinus region. There was a lot of interest in anatomy and physiology, notably from Professor Messerklinger in Graz, who showed that there was mucociliary clearance along the mucosa, taking the mucus into the osteomeatal complex. And so originally, the focus of our attention and of the disease was thought to be the osteomeatal area, and that the objections of the surgery were to restore ventilation and drainage. Now, of course, surgery doesn't lend itself very well to placebo-controlled randomized trials. So we were very reliant on opinion-based medicine. But of course, we had guidelines being developed. Certainly, I was involved with one back in 1994, one of the first on the nose and sinuses. And these really exposed the big gaps in our knowledge and our approach to treatment. And so if we couldn't do an RCT, at least we could collect prospective data. And that really took us into the age of medicine, of evidence-based medicine, and of course, with that, individualized medicine and precision surgery. And so you see the emergence of documents such as EPOS starting in 2005 and most recently published in 2020 as evidence-based reviews on the topic, and getting bigger and bigger as the evidence base increased. And of course, we have ICAR also produced and reproduced as the literature increased most recently in 2021. So here we all are at the first International Advanced Sinus Symposium in Philadelphia in 1993. Bright-eyed, bushy-tailed. Sadly, some of the people in this picture are no longer with us. But they combined over the period of time from the early 1980s onwards for sinus surgery really to spread around the world in the most impressive way. Of course, different acronyms were applied, different philosophies. Many people were involved in this process, starting with Professor Stamberg and Professor Kennedy, but many, many people contributed to this. But of course, with time, we realized that it's not just about ventilation and drainage. And now we talk about how much surgery should we do? Is it preservation of mucosa, or is it radically stripping everything out? Does it depend upon the phenotype or endotype of the disease? Certainly, the evidence suggests that for more severe disease, bigger is better. But until quite recently, we still rely on a combination of medicine and surgery. With time, we were able to accrue large prospective cohorts, which showed that endoscopic surgery worked very well, improving quality of life from 3 months post-operatively to 5 years and beyond, whether patients had polyps or not. But we also found from things such as the UK sinonasal audit that if you have your surgery sooner rather than later, within 12 months of the onset of symptoms, then your chances of success and improvement are much greater than if you wait for years and years. Now, why would that be? Well, of course, one is reducing inflammation, one may be preventing irreversible change in the mucosa, the microbiome, or the underlying bone. And in addition, and perhaps very importantly, we're allowing the better delivery of topical medication. So while surgery is effective, about 2/3 of patients derive significant benefit, we know that 1 in 2 will deteriorate after 6 months, and that will lead on to revision surgery and repeated courses of corticosteroids. And that's particularly true of patients with polyps, shown in the blue column in this histogram at 5 years. This review by Loftus looked at revision rates for patients with polyps in 45 studies and showed that the overall rate was about 19%, which is quite a significant number. And we've also shown that recurrence, if it occurs within 3 years of the first operation, have much greater chances of future revision surgeries and recurrence. So that time to failure after surgery may help us to select the patients who are not going to do well from repeated operations and should be considered for other alternative strategies in the era of biologics. So here's my timeline for evolution of CRS management. And of course, apart from the surgery, we also have a lot of medications coming along during that period, notably ending up with the biologics. And if we look in our consensus documents, we see a lot of time and effort is provided to get together all this medical treatment into recommendations and algorithms. Here is the one from ICAR and a similar one from EPOS. And we are now trying, I think, to look at our patients more sensibly, to divide them up by endotype into those who are predominantly type 2 or non-type 2 in order to provide the most appropriate treatment. Along the way, we've got lots of toys, image guidance and navigation, powered instruments, balloons, better drills, and image guidance, as I've said. These have all made big differences to the way in which we undertake and deliver our surgery. And we've also got better ways of actually delivering our medication, notably from the eluting stents, which allow us to put high doses of steroids into a very precise area. So since the 1980s onwards, we've seen this progression of applications to many sinonasal conditions, some of which you'll be able to see today. But of course, inevitably, we started to move outside of the sinuses into the orbit, into the skull base. And if we could control things in the orbit and CSF leaks on the skull base and also hemorrhage, then of course we could also tackle benign and malignant tumors and other conditions even beyond. So if we look at the evolution of our surgery and our chemoradiotherapy treatment for sinonasal cancer, we can see that, again, we move from those operations from the end of the 19th and early 20th centuries through conventional craniofacial resection in the 1970s to the widespread application of endoscopic surgery for sinonasal cancer. And that too has gone hand in hand with developments and evolution in imaging and chemoradiation. Of course, it's very important when we do this sort of surgery that we apply the same principles of complete tumor removal, surgery with curative intent. If we do our surgery endoscopically, then it doesn't matter if it's piecemeal or disassembly. One of the first of the consensus documents looking at this area was this one published in 2010, and this critically analysed the published literature at that time, which was mainly small case series. What it emphasised was the need that we have to collect prospective data. And if we do that, then we can see in this personal series of 170 cases that whether the patient has an olfactory neuroblastoma on the top line or a malignant melanoma in the green line at the bottom, then with patient selection done carefully, we will end up with the same results, if not better, than we had with conventional approaches. And this is because we can tailor our surgery to the individual who may have a shorter stay in hospital with fewer complications. They can commence their chemoradiation earlier, and that minimal morbidity may translate into less disturbance of the immune balance. And as we'll hear today, those limitations are evolving all the time. And of course, we now have critical reviews and evidence-based guidelines in this area. And what they emphasize is that with these rare diseases, we need multi-institutional collaboration, which the Academy has been great at fostering. We need multimodal protocols, allowing personalized treatment, and we need databases for long-term outcome and tumor banking. We certainly aren't short of advice on how to do it. There are many, many books and papers on this area. It's become a very sexy area of ENT and head and neck surgery, the skull base. But the thing that makes me most proud is that we've been able to set up international networks for outcome and genomic analysis. And we now have databases through USECA and INSECA of over 3,000 patients from over 25 centers, allowing us to accrue big studies, cohorts, to get robust statistics and know how best to treat our patients. So I'm pleased to say that I have been very lucky to live through a golden age in rhinology. I've been lucky to be in the right place at the right time. And I think I can say that it's also been a golden age in endoscopic sinus surgery. And that's what we're going to find out later in the grand round as we will see the demonstrations. Thank you so much for including me.
Professor Lund, thank you so much for an exceptional presentation. You took us on a truly captivating journey through the evolution of endoscopic sinus surgery, weaving history and innovation with such insight and expertise. We ask the attendees to ask questions through the chat. Professor Lund will answer some of these questions in the chat and then in the question and answer session that follows the presentation. We are privileged to have Professor P.J. Wormald share his expertise on complex frontal sinus surgery, offering valuable insights into the challenging and evolving field. From the other side of the world, let's welcome Professor Wormald.
So thank you very much. It's a pleasure to be with you, and it's a privilege to be included in the grand rounds. It's getting close to midnight here in Australia, so I'll try and be brief, but try and share some of my insights with you into complex sinus, frontal sinus surgery. Those are my disclosures. There's nothing that's relevant to my current presentation today. So what is complex frontal sinus surgery? Why is it difficult, and how do I do it? Are the three areas that I really want to cover today. So complex frontal sinus surgery really is dependent upon two things. One is the number of cells that impact the frontal ostium. As we can see on that CT scan, this is a very complex frontal sinus with a large number of cells in and within that frontal ostium. We also, the AP diameter of the sinuses is absolutely critical. So if we have a very narrow AP diameter, we are going to be very much more difficult surgery than if we have a widely pneumatized frontal sinus with easy access into that frontal sinus. So these are the two things which really make frontal sinus surgery difficult. And if we look at the International Frontal Sinus Anatomy Classification, which we published in 2016, just the terminology that I'm going to be using, I just wanted to outline it so that everybody is with us. It's a very simple, straightforward classification. The Agonizing cell, any cell that sits above the Agonizing is called a superagar cell. Any superagar cell that goes into the frontal is called a superagar frontal. Agonizing, superagar frontal. Then we have the bulla ethmodalis. Any cell above that is a suprabular cell. Any suprabular cell that goes into the frontal is a suprabular frontal. So very simple. Bulla, suprabular frontal. Agar, superagar frontal. Really straightforward, easy to remember, and that's the nomenclature we're going to be using today. We're also going to be looking at the extent of frontal sinus surgery, and we're looking at three areas, really: no tissue, removal of cells, and removal of bone. And in this particular presentation, we're only going to be looking at grade 1, 2, and 3. So we're only going to be looking at cells that are below the frontal ostium, obstructing the frontal ostium, or going through the frontal ostium. So this is the area we're going to be addressing. We're not looking at utilization of any drills or widening of the frontal sinus with drills. That's not part of the presentation. So what do we do when we're faced with, on the left-hand side, with a very complex frontal sinus scan? And I think in America, what happens nowadays is everybody turns to image guidance. So everybody says, oh, well, if it's a complex frontal sinus, I'm going to use image guidance. And it's probably standard of care in the USA, but you just have to look through where all the participants on today's webinar are from, and you'll know that image guidance is not routine in a lot of the areas that we have. And even though we still have image guidance as standard of care in a lot of the centers, we still have complications. So image guidance, although it's a great benefit if you have access to it, is not something which can substitute for anatomical knowledge. You can't rely on your image guidance. You've got to rely on your anatomical knowledge, and you can confirm where you are with your image guidance. The image guidance is not what takes you to the frontal sinus. Your knowledge takes you to the frontal sinus. The image guidance is your safety if you have it. And you should always have a surgical plan. This is critical. And so we're going to go through this with you. So frontal sinus dissection really results in complications when surgeons are trying to find the frontal ostium. So the classic mistake that's made is the surgeons don't have a surgical plan, and they start to do a dissection in the frontal recess, and they start to probe for the frontal ostium. And when you start to probe for the frontal ostium, you're starting to push your instrument into the skull base. Now, there's a lot of schools of thought that say the best way to dissect the frontal ostium is to start in the sphenoid. Now, if you have no anatomy and your patient has had previous surgery, this is a good place to start. This is a good way to go about dissecting the frontal ostium if the patient has had multiple previous surgeries and anatomy is gone. But in a patient who's got good anatomy, if you start in the sphenoid sinus and you start to probe your way forward, what happens is that you're tending to try and find the frontal ostium with your probe, and you're pushing your probe through the skull base. It's the most common cause for a CSF leak. The most common cause is a surgeon probing for the frontal ostium, and while he's probing, going through a thin area of the skull base into the anterocranial fossa. So probing blindly for the frontal ostium is not something that we would recommend, and it's not something that you should do. You should have a surgical plan, and you should have a particular way to go about finding that frontal ostium. So I like this analogy. So if you have a complex frontal sinus and you're in a maze and you're trying to find your way out of the maze, and I didn't know much about mazes. So what I did is I went and researched mazes. And they say that if you're in a maze and you put your hand on the wall, that you'll get out of the maze. I went and downloaded a whole lot of mazes, and then I put my hand on the wall, and then I went to see if I'd find my way out of the maze. And you will always find your way. If you don't lift your hand off the wall, you will find your way out of that maze. So where is our hand on the wall? So your frontal process of the maxilla is your hand on the wall. So when you're trying to find the frontal ostium, you're going to identify the frontal process of the maxilla, and you're going to use this like your hand on the wall for your lost in the maze, if you think about that analogy. So if you keep the frontal process in view while you understand your surgical plan, and you keep it in view, and all of your dissection is done with that frontal process in view, you will not then damage that skull base. You're not going to go into that skull base and create that CSF leak that you're going to do. So keeping your hand on the wall and remembering that the angulation for a narrow AP diameter is always significantly more than you think. So the problem that we have, if you're starting at the back and moving your way forward, is that you're not angulated, you're not seeing the frontal sinus, you don't know where you are, you're probing blindly, and you're going to find yourself in trouble. So we want to avoid that if we can. So we want to be having our hand on the wall all the time. So I want to give you an example. So we have here a very complex frontal sinus in a patient who's got chronic disease, lateralized middle turbinate, a number of cells impacting that frontal ostium. So what we want to do is first thing we want to do is understand the anatomy. So we use the building blocks. So we identify the Agonizzi cell. So we find the Agonizzi cell, we find the supra-Aga cell. And in this particular patient, there are two supra-Aga cells, one next to each other. So we understand that above that Agonizzi cell are two supra-Aga cells, and above that is a suprabullofrontal cell, which is coming along the skull base and entering that frontal sinus. And then once we understand that cellular configuration in the frontal sinus, we then can proceed to work out the frontal drainage pathway. And to do that, we start high up in the frontal, using the axial scans, identify where the drainage pathway goes in relation to those cells. Because remember, we're going to find our hand on the wall, we're going to dissect the cells around the hand on the wall, and then understanding the frontal drainage pathway, we're going to find our way into that complex frontal sinus. So that having that surgical plan and planning that surgery is absolutely critical. So here we have the patient that we've just done the planning on. So this particular patient, we're going to trim this middle turbinate, and we can discuss when and where and how we trim middle turbinates these days. We're going to then find our Agonizzi cell. So you want to find your hand on the wall. So the way to find your hand on the wall is to find the Agonizzi cell. So open up the Agonizzi cell. This particular patient is full of pus. So open up, clear the polypoid tissue. So here we're clearing just the polypoid tissue so we can see the Agonizzi cell. So we don't want to take the cell away. We want to clear the polyp out of the cell, identify the cell, and then go behind the cell, fracture the cell forward, onto the frontal process. So the whole dissection is hand on the wall, keeping the frontal process in view all the time. This is absolutely critical. So we really want to make sure that all of this dissection that we now are doing, taking away that posterior wall of that Agonizzi cell, identifying as we go up the supra cells. If you remember, we had two supra cells that we had above the Agonizzi cell. And then once we've taken away that posterior wall of that Agonizzi cell, we can visualize that. So here we can see hand on the wall. So here we can see frontal process, hand on the wall. One supra cell here, one here. So we've got two supra cells. We know that the drainage pathway is behind those supra cells. So now we're going to take the supra cells away, and we're going to expose our hand on the wall to find that frontal ostium. Following that hand on the wall, following that frontal process all the way up to the frontal is absolutely critical to staying exactly, knowing exactly where you are each step of the way and finding your way into that frontal sinus. Absolutely critical. So here we can now see the suprabullofrontal cell. Drainage pathway is going to be here, which is medial, which we could see on that scan. So now we're going to identify the drainage pathway into that frontal sinus so that we can clearly see exactly where we are. So here we can see we're going to open up the drainage pathway to the frontal sinus. We're going to put our instrument up that drainage pathway, fracture laterally that supraagofrontal cell so that we can expose that frontal ostium and remove and clear that frontal ostium completely. So this process of knowing what cells are sitting adjacent to your hand on the wall, taking those cells away one step at a time, always keeping your frontal process in view, allowing you to open up and dissect out that frontal sinus. So how do we get our hand on the wall? So to get your hand on the wall, you need to open the Agonizzi cell. You need to find the frontal process. This is the Agonizzi cell. This is the frontal process. To do that, we do the axillary flap. 10 millimeters above, 10 millimeters anterior. We elevate the flap. We cut the flap with the middle turbinate so that we can fold the flap away, take a Hayjack-Koffler punch, open up the Agonizzi cell, visualize our hand on the wall. Now, you can do this without doing the flap. The flap just prevents the secretization in the postoperative period. So if this disappears or goes up the microdebridor or whatever, don't worry about it. It's not the end of the world. But the only thing the flap is there for is to prevent the scar tissue from folding and narrowing this down in the postoperative period. And the reason that we designed the flap was that when we didn't use the flap, we saw that this portion of the middle turbinate would tend to lateralize a little bit towards that frontal process, and just pulling that flap back prevented that from happening. So if you look at this particular patient who's got a very narrow AP, first of all, identify the Agonizzi cell. Find that Agonizzi cell, open it up, and then identify the cell above that Agonizzi cell so that you can visualize it, and then know that you've got an Agonizzi cell and a supra cell, and then we can identify our drainage pathway. So take away that, identify the drainage pathway, see where that drainage pathway is, go in the axial scan, identify how the drainage pathway runs relative to those cells, and then we go into our surgery and then open up that Agonizzi cell. And when we open up the Agonizzi cell, we can then take away the roof of it and then find the supra cell. And once we found the supra cell, we remove that, but we always can see our hand on the wall. This is a patient with a very narrow AP diameter. So now we've taken away, there's our hand on the wall. So we can see our frontal process. We've taken away the roof of the Agonizzi cell. Now you're looking at, is that a cell? Are we looking at a cell? So when you have a narrow AP, always remember your angulation. So we have a 30-degree endoscope now. But if you drop that endoscope down, look what happens. So as we follow that up and drop that endoscope down, is this a cell? Or is this the frontal sinus drainage pathway? There you can see the frontal sinus. So this is not a cell. So don't try and take this away. You need to drop your scope down when you've got a narrow, or change your angulation in your scope so that you can visualize that frontal sinus, that you can see into that frontal ostium. So finding your hand on the wall, remembering that your angle of entry, if you look at your angle of entry here, it's quite acute. It's not 90 degrees, it's even more than 90 degrees. It's really important that you remember when you've got a narrow AP diameter that you need to have a significant angulation on your endoscope so that you can go around the corner to identify your frontal ostium and visualize it. So my conclusions are, what makes a difficult frontal sinus is a narrow AP and the cells that impact that. So the more cells that you have going through or into that frontal ostium, the more difficult it becomes. So cells that are below the os, in the os, or through the os always impact that. Understand the anatomy. Don't rely on your image guidance. Find that frontal drainage pathway using your axial scans to go from the frontal sinus all the way down, identifying the drainage pathway. So if you're finding that drainage pathway and then know where to place your instrument to be able to fracture those cells away, you then create a safe environment. The steps that you need to follow: open the Agonizzi cell, find your hand on the wall, know that the cells that surround that, in other words, understand your anatomy, keep those cells in view, keep the hand on the wall in view so that you remember the angle of your entry into that frontal sinus that gives you a safe entry into that frontal sinus. Now, this is software which is free, and I don't have any relationship with Stryker for this, but you can download the software for free and you can utilize the software should you need to. So thank you very much and happy to take any questions.
Thank you, Professor Wormald, for an outstanding, didactic, and insightful presentation on complex frontal sinus surgery. We will all remember, keep your hand on the wall, and your expertise and innovative approaches continue to advance our field. Congratulations on a truly remarkable session. Again, we ask the attendees to ask the questions through the chat. Professor Wormald will answer some of these questions in the chat and then in the question and answer session that follows the presentation. I am delighted to invite Professor Rodolfo Nazzar, who will share his insights as he presents on extended access in endonasal surgery, offering his valuable perspective on this advanced approach. Please join me in welcoming Dr. Nazzar.
Thank you very much, Pablo, for the presentation. It's a pleasure to be here. And we are going to talk about the extended approaches in endoscopic sinus surgery. So I am from Chile. Thanks for the invitation. Like introduction, I want to talk about that functional endoscopic sinus surgery has significantly evolved over the past decades, enabling a minimally invasive and highly effective approach for the treatment of complex pathologies. The concept of extended approach involves surgical expansion beyond the traditional limits of basic endoscopic techniques. And we will explore the indications and surgical techniques associated with the extended approach in functional endoscopic sinus surgery with a focus on different sinuses. In relation with the maxillary sinus approach, we can have the standard limited approach with the onsinectomy and meatalantrostomy. And when we talk about extended approach, we talk about megantrostomy, medial maxillectomy, Denker's approach, prelagrimal or transeptal approach. All of this approach can be considered extended approach because you go beyond the limits of the sinuses. In relation to medial maxillectomy, you of course, open the uncinate, the bulla, and you resect the medial maxillary wall, including or not the nasolacrimal duct. If you resect the nasolacrimal duct, you are making a radical maxillectomy. If you preserve the nasolacrimal duct, you then perform a modified medial maxillectomy. A very interesting approach that I use a lot in my patients is the prelagrimal approach, where you can see in this video is a patient with a nasal polyp. It was already operated, and you can see how we are performing an incision on the lateral wall at the level of the inferior turbinate. You are exposing the maxillary process, and then you can resect the bone with an osteotomy or with a Kerrison. And then you are going to have a very good vision of the maxillary sinus, entering with a window on this part, and you can control all the sinus, and you control all the walls of the sinuses. You see here a nice view of the posterior wall. You are then working from the nose and inside the sinus also. This is a very interesting approach. I perform a lot in my patients, and I have got results. Another extended approach of the maxillary sinus is the modified Denker's approach, or Sturman-Canfield. It consists in a radical medial maxillectomy plus a resection of the piriform aperture, and then you control all the sinus. It's indicated for recurrence and also for access of the pterygopalatine and infratemporal fossa, and then you can control all the walls of the sinus. Of course, it's more aggressive, but it has some indications. In relation with the frontal sinus, I'm not going to talk too much because Professor Wormald already gave us a wonderful presentation, but just remember that the extended endoscopic approach, according draft, is draft 2B and draft 3. Draft 2E, it consists in an opening of the frontal sinus from the orbit till the middle turbinate, and the extended approach of the frontal sinus is from draft 2B, and then you perform an opening from the frontal sinus, from the lamina papyracea until the septum, and then you resect the middle turbinate. And then finally, you have the draft 3, that is a medial approach. Then you open the frontal sinuses from orbit to orbit, and then you resect the superior septum and the interfrontal septum. Here is a patient with a fungal sinusitis, allergic fungal sinusitis. You see all the compromise in the CT with mucocels. You see here in the surgery, we open both frontal sinuses. You can see here the dural pulsation because the thinning of the posterior wall of the frontal sinus. And then you perform a big opening from both frontal sinuses. You see here the allergic mucin, the inflammation, and then you can go with the drill, resecting the interseptal septum, the interfrontal septum. And then you go inside the both frontal sinuses, resecting a supra agar cell. Here you can see and have a big opening of both frontal sinuses. If we are lucky and we have a good healing, we can see the patient in the postoperative with a very good healing. Also, this patient became some biologics, and he's totally free of disease after 2 years of operation. Here I want to show you our casuistic at the clinical hospital in relation with the frontal sinus. From all the indication of frontal sinus surgery, half of the patients have chronic rhinosinusitis with polyps, 20% mucocell and abscess, 15% papilloma, inverted papilloma, 10% chronic sinusitis without polyps, and 5% fibroosseous tumors. From all the patients with nasal polyps, 30% have chronic sinusitis with polyps. They have AERD, Sumter's triad. Here you can see the numbers of surgeries per year. You can see how we increased the numbers of surgeries per year since 2013. And the procedures that we perform the most frequent procedure, draft 2B and draft 3. From all the extended procedures in the frontal sinuses, 70% of the patient, we perform draft 2B, and in 30% draft 3. From all the patients with draft 2B, we perform in 60% a unilateral procedures and in 40% a bilateral procedure. In relation with the ethmoid sinuses, we can have a standard ethmoidectomy, which have a recurrence rate of around 60%. And also we can perform a radical ethmoidectomy if you resect all the cells and if you also resect the mucosa. And the recurrence rate is lower, it's much lower, you see 20%. In this case, you preserve the mucosa, and in the radical ethmoidectomy, you can perform the nasalization. Here you can see the total ethmoidectomy, and you can have a very good delivery of medication and drugs with this kind of approach. A systematic review compared the outcomes of different extent of approach in patients with ERD, the limited anterior ethmoidectomy versus total ethmoidectomy. In the group with total ethmoidectomy, this group had lower rates of revision surgery and lower SNOT 22 scores without an increased complication rate. But if you compare the total ethmoidectomy versus the extended ethmoidectomy, it consists with the resection of the middle turbinate, no additional benefits in nasal symptoms severity measured by visual analogic scores or in nasal polyps score have shown. And finally, the extended approach to the sphenoid sinus consists in a bilateral sphenoidectomy. We know very well this access for the skull-based surgery when we perform adenomes of the hypophysis, and it consists in a resection of the posterior septum, resection also of the sphenoidal rostrum, and you can resect also the intrasphenoidal partitions, and you can have a big opening of both frontal sinuses, of both sphenoidal sinuses. The indications are access to the lateral sphenoid recess, large mucocelles or fungal balls of the sphenoid, and extensive polyps, and also access to the skull base. Here you see a patient with a recurrence of sphenonasal polyps. We perform a big opening from both sphenoid sinus and also free of disease after 2 years. So in conclusion, we can tell that the extended endoscopic approach advantage are that is a minimal invasive tool with lower morbidity. It provides a better surgical visualization with this kind of approaches, and permits also the administration of optimal topical medical therapy. And the indications are refractory chronic sinusitis, aggressive phenotypes disease, different kinds of tumors, benign or malignant, and also the management of skull-based pathology. Finally, I want to invite you all the friends over the world to our Pan American Congress that will be in Santiago de Chile the next November in Santiago de Chile, and where I will be the president. Thank you very much for the kind invitation.
Thank you, Professor Nazzar, for your remarkable presentation on extended access in endonasal surgery. Your valuable perspectives and experience have been certainly impactful. And yes, we're planning we're going to be joining you in Chile very soon. Now we're going to open the question and answer session. We have received some through the chat, some through the Q&A. Dr. Crespo, we'll start with questions for Dr. Professor
Lund.
Lund.
Yes. Well, thank you, everyone. I love your talks. Dr. Lund, it's very interesting, your perspective since the beginning of times. You've been with sinus surgery, you've been at the beginning of this. So I was wondering if you could have your input, or you can tell us a little bit of how you see endoscopic sinus surgery moving forward, not with the coming with artificial intelligence. How do you see that it's going to move forward this field of endoscopic surgery?
Well, I wish I had a crystal ball, but sadly I don't. I mean, I think generally it's a bit harsh just to show a line showing endoscopic sinus surgery, because it's been changing all the time. And we see it changing in response to lots of things, not just AI, but many other factors have altered our approach. And I mean, one of the things that's going to make the biggest difference to surgery for CRS, for example, is the biologics, because we've already seen big changes in the amount of revision surgery that's required. And, you know, we might in time have the option of giving biologics at quite an early stage in the disease, which might alter the natural history to such an extent that surgery either isn't required or is, you know, after the first operation, it's probably not needed. Now, you could argue that isn't going to happen because the biologics are very expensive and, you know, do patients want to be on drugs for life? But I think there are going to be some shifts like that. It's very difficult to, you know, second guess exactly what's going to happen from a technologic point of view. I think the most important thing is that there's a gradual realization that we, you know, have to work together, not just within our specialty, but with all our colleagues, so that we have a sort of multidisciplinary approach to our patients. And that allows us to bring in other techniques as well that are used in other specialties, be it maxillofacial, neurosurgery, etc. Those are things which have influenced us quite a lot, and they, and also with our medical colleagues. So I don't think alone we can say, you know, surgery is going to do this, that, and the other. What's going to happen, I hope, is that there will be a greater collaboration and endorsement of other ideas and technologies and philosophies that will alter what we do. But I'm sure the companies have got lots of ideas about what's going to come along next, and I'm sure that AI is part of it. Though I, as you pointed out, I've been doing it since the beginning of time. Well, I doubt that I will be employing AI in my future practice as such. But who knows? I mean, things have changed so much in a short time.
Thank you, Professor Lang. I have a question for Professor Wormald, and one is, do you use draft 3 in patients that had unilateral frontal sinus papilloma?
Yes, I do. So if you've got inverting papilloma in the frontal sinus just on one side, you generally need to get very good access to that frontal sinus. So you need to be able to reach the lateral extent of the frontal sinus. And if it is significantly pneumatized, you cannot do that through a unilateral approach. So I would use a frontal drill out draft 3 or whatever you call it, modified Lothrop procedure, to give me that access from the contralateral nose across to the opposite side. So for instance, if you've got inverting papilloma in the left frontal sinus, then you need to be working from the right nostril across that angle of attack across from the one sinus across to the other allows you to reach that far lateral aspect, and to be able to get a good clearance of the mucosa allows you to use angled burrs, diamond burrs, to be able to drill the bone so that you don't get a recurrence. And it also gives you that ability in the post-operative period to monitor that patient for any recurrence, because you've got a big access into that frontal sinus. So definitely would use modified Lothrop draft 3 frontal drill out procedures for unilateral inverting papilloma.
All right. I have a question for Dr. Nazzar. So what other landmarks do you use in a case of revision surgery when the landmarks are obscured?
So especially for the frontal sinus, a big help for me is the maxillary process. Like Professor Wormald say, we need to touch the wall, and the most constant landmark is the frontal process of the maxilla, and also identify very, very soon in my surgery the lacrimal way. You know, if you identify the lacrimal way, you are very sure that the frontal sinus is behind and above the lacrimal way, and it's a very constant landmark, you see. If you have also the middle turbinate that is not already resected, of course, that can be a landmark. But if you don't have nothing in the nose, everything is operated, the lacrimal way is the most constant landmark for me.
So, and I had another question, Dr. Nazzar, about your extended procedures. Sometimes, especially in revision cases, you're going to have postoperative neosteogenesis. I was wondering if you can give us a little bit of your input of what do you use to avoid the situation if you ever use like a mucosal graft, let's say for the frontal when you drill. What is it that you can give us a little tips and tricks?
So in some case we use the flaps in order to cover the free bone, you know, but we don't use routinely. We debride a lot in the postoperative care, and also we use very soon the nasal irrigations, and with steroids inside with budesonide, with pulmicort, you know, and we can prevent some stenosis, especially of the frontal sinuses. But I don't know if Professor Wormald has some advice in order to prevent the stenosis of the frontal sinus. That is the most difficult for me in some cases.
Yes, please, Dr. Wormald, help us with this question.
So, I mean, there's very many different ways to prevent the frontal sinus, but probably the most important is to make sure that all of the cells have been removed and that you've widened the frontal ostium where you can without a drill. So using things like the Hoseman, like a Cobra, the instruments that allow you to take those septations from the frontal to get the widest AP and lateral dimension of the frontal that you can at the time of surgery is really important, but equally important, preserving the mucosa and the frontal ostium. So if you've stripped the mucosa, you're not going to have a great result. You're always going to be struggling if you've stripped the mucosa. So preserving the mucosa in the frontal ostium, but utilizing those instruments to get the widest AP diameter. And then, you know, there's a lot of post-operative dressings to put inside, and I'm sure Medtronic would want to talk about, you know, their drug-eluting stents and that. And there are others as well, Chitogel and different other products that you can use in that frontal ostium to try and prevent that stenosis. So, you know, looking at what's available to you in terms of what's cost effective as well for you and looking after that frontal ostium in the post-operative period, looking after your patient at the first post-operative visit, making sure that ostium is clear, that you don't have any coagulum, which allows the fibroblast to grow into that coagulum and narrow that frontal ostium down. So getting that post-operative debridement going is really important as well. So, you know, I think there are lots of different options, but intraoperatively and post-operatively are probably equally important in terms of preserving that frontal ostium.
Thank you. We have time for one more question. I know there are quite a few on the chat, but this last question will be to Professor Lund. And, you know, there are many algorithms that talk about appropriate medical therapy. What has been your algorithm before you make a decision to proceed with surgery?
Well, you know, it's a pragmatic thing. And as has already been said, depends what's available to you. But I think, you know, most people agree that a reasonable trial, whatever that might be, 6 to 8 weeks of some form of nasal irrigation and some form of intranasal corticosteroid is generally accepted as the usual. Whether you then, are willing to add in oral corticosteroids or even a long-term macrolide rather depends on your philosophy and where you're working. But I think the most important thing is to have that conversation with the patient as to what they feel is appropriate. And of course, these days we do, I think, need to be thinking about what our patients actually have got. Is it a disease which is predominantly type 2, or is it one that is not? In which case that will determine your next step in terms of steroids or macrolides, for example. But generally speaking, 6 to 12 weeks of a intranasal corticosteroid and irrigation. And, a proportion of patients get better with that and never come to ENT surgeons. We all have a very biased view because we're always going to see the patients who failed. And that would be my determining factor.
Well, thank you all very much to our outstanding faculty today. We know it's late in Australia. We know it's getting late afternoon in London, and Chile, you're in our time zone. So we'd like to thank you so much, and we're going to turn the program now to Dr. Jolie Crespo, who's going to do the introduction of our lab faculty.
Yes. Well, yeah, now we're going to move to the advances techniques in endoscopic sinus surgery. We're going to do a live dissection. We have Dr. Joseph K. Hahn. Dr. Joseph Hahn is a professor in the Department of Otolaryngology and Head and Neck Surgery at Old Dominion University at Eastern Virginia Medical School. He's currently the Vice Chair of Clinical Affairs of Administration, former Chief of Division of Rhinology and Endoscopic Sinus and Skull-based Surgery, and he's also the Chief of Division of Allergy. Dr. Hahn is very active in both basic science research and clinical research studies, and has been awarded over 70 funded clinical studies. His thesis was on subclassification of CRS, which is the endotyping and phenotyping of CRS. He has been a leader in international investigation in CRS and has been awarded the NIH fund for the bench research study of chronic rhinosinusitis. And also we have and it's an honor for me to introduce one of my mentors, Corina Levine, which is associate professor at the University of Miami in the Division of Rhinology and Skull-based Surgery, where I'm a former fellow, very proud of. And I was firsthand being able to watch her practice, which focuses exclusively on CRS and endoscopic sinus surgery for benign and malignant sinonasal and orbital tumors and repair of skull defects. Dr. Levine is also the Director of Clinical Rhinology Research. She is the recipient of several grants, including the Triological Society Career Development Award at the University of Miami. And her research focuses on CRS outcomes through precision health approaches to care and addressing CRS healthcare delays. So now we're going to start at our Medtronic lab.
Okay, great. Thank you, Dr. Chris, for the nice introduction. So, today what I'm going to do, we're going to break up the cadaver dissection into 2 sections. I'm going to do the first one where I'm going to do an endoscopic septoplasty, talk to you about the different techniques. I'm going to also talk about endoscopic DCR, and then I'm going to finish up with a maxillotracheostomy with a medial maxillectomy, endoscopic medial maxillectomy. Then I'll take some time to answer some questions while we're setting up for Dr. Levine, and then she will do frontal sinus procedures, different levels of frontal sinus dissection, SPA artery, endoscopic SPA artery ligation, and endoscopic orbital decompression. And then if we have time, we do have other advanced endoscopic procedures we can do, like endoscopic anterior ethmoid artery ligation, but only if we have time. And so let me go ahead and start first. We did try to maximize the dissection by doing some work a little bit ahead of time. So I'm going to take a look inside the nasal cavity of our cadaver. So this is the right nasal cavity. And so if we look here, we can see here's the septum, inferior turbinate, here's the middle turbinate, and you can see that the Medtronic lab has dissected out the blood vessels, the veins to be blue, and the arteries to be red. And so here we see that the septum is deviated to the right side compared to the left side, which is much more open right there. And so when I'm trying to do endoscopic septoplasty, for me, the reason why it's helpful is when I'm teaching residents, you know, I can see what the residents are doing. And so when I try to do endoscopic dissection, I don't try to remove all the the deviated septum and cartilage. I only take out only the part that's deviated that obstructs the nasal cavity and prevents me from seeing the sinus cavity. So what I can see is the axilla there. And so what I want to do is take out this here and that part, and I don't do more than I need to. And so I already made an incision. So you want to make a hemi transfixion incision. And so we already made an incision here. And you want to, in order to do an endoscopic septoplasty, what you really have to do is maximize the incision that you make. And so you want to make the incision as low as possible and as high as possible. And so, and I usually make it a little bit further back than the traditional hemitransfixion inception. And so here now we can see that we're in the right tissue plane. And here's the cartilage. You can see some of the arteries there that are colored. You can see some of the veins that are there. And then I think what's helpful is to use endoscope cleaner. And so the Medtronic has an endoscope cleaner. It's called the Endoscrub. I'm going to show you a picture of it. This is what it looks like. It connects to the endoscope. And what you can do is then you can irrigate. So while you're in the nasal cavity, you can irrigate into the nose. And I'm going to go ahead and irrigate. And then, and so you can irrigate and clear things up as you're going along. And so now I'm going to go ahead and get a freer. What we see here is that when you're in the right tissue plane, you don't get a lot of bleeding. And a lot of times I see the residents kind of push to do the dissection. But what you want to do is nice sweeping motion. And you can see the nice fibrous tissues that's separating from the cartilage and the artery. And then what you want to do is, and you can make sure that you're right in the right tissue plane. And if you're in the right tissue plane, you really shouldn't have a lot of bleeding. And so here, this is that deviated bone and cartilage that I'm expecting to take out. And I always take out a little less than I think I need. And so, so what's nice is endoscopically, you can then go back and take a look, and you said, this is what you want to take. You want to take it to the level of the axilla. And that way, if you take it to the level of axilla, you know you have enough of a dorsal strut that you're going to leave there in place. So what I'm going to do is I'm going to take out that part, and then I'm going to go back endoscopically through the periosteum, and then here is that part I'm going to try to take out. And then what's nice about the stuff is I use a freer to make cuts. And, you know, if you're cutting through cartilage, I don't use the blade. And so you can see that endoscopically, you didn't get all that tissue. You know, you can see that there's another layer of mucoperichondrium I could have probably taken down. So I'll use the freer to cut through the cartilage. I'll go all the way to the osteochondral junction. And then if the residents are doing all this, I can see them doing all this, because the worst part for me is for the residents to go too high. And you can see endoscopically, you can see that there's still a lot of tissue planes that I should have dissected out. With the headlight, you cannot see it, but with the endoscope, you can see that. And so now what I'm doing is I'm just taking out the cartilage. And so you can see I'm taking that out in a straight place, please. And then, so now I'm taking out the cartilage. And then, so now I'm going to dissect out the freer. And so now I'm going to elevate the mucoperichondrium on the other side. And so I'm going to elevate that. And so here, and I can see that on the right tissue plane, I'm going to use a double action scissor to cut through the part of the bone. So I took out the cartilage. Now I'm going to take out the bone. And when you're doing this, you want to make sure you elevate the mucoperiosteum and perichondrium, and before you cut the bone or cartilage. So now all I want to just take out that part. So I'm going to get a double action scissor. And so I'm going to go ahead and cut the bone. And then, and what's nice, so what's hard about the endoscopic septoplasty is that you don't have any frame of reference. When you're doing sinus surgery, you have a lot of frame of reference, whether it be the choana, the middle turbinates, straight Blakeslee. You could see where the references are. But when you're doing endoscopic septoplasty, you're between the two mucosal flaps, so you can't see exactly where you're going. And so that's why it's important for me to make sure the residents aren't going too high, because if they go too high, they'll get a CSF leak. And actually, for me, the CSF leak, you can see there's a little artery in the septum right there. And so, getting a CSF leak in a septoplasty is not that big of a deal because I can repair it and fix that. What I can't fix, what I can't fix is if they go too high and lose their sense of smell, all of a sudden that's something that I can't fix, and it's very hard to have the patient improve that. And so now, what you can see now is I've taken out the cartilage and I've taken it to the axilla, and I knew I didn't take it as high as I wanted to on purpose because now I can feel it and I could see that that this is the part that I've taken out. I just want to take out just a little bit more. So it's about the width of my freer. So I'm going to go back in there and then take a look. And then I want to take out about the width of my freer up here. And so I'm going to use my freer. And then do we have an open Jansen Middleton? Oh, open Jansen Middleton or Blakeslee is fine. And so I'll use an open Jansen Middleton to cut out a little bit more if I need to. And so here with the endoscopic view, you really can see everything really well. I mean, in terms of setup, it does take a little bit more, but I think it's worth it for the visualization. And especially if I'm teaching residents, I definitely want to be able to see what they're doing. And so straight Blakeslee, I definitely want to be able to see what they're doing. So I think it's nice to have. Can I get that scissor next? So I'm going to take out the septum and then the scissor. I'm going to cut out the bone. And then what's nice is then after I take out this part, straight Blakeslee, then I can go back in and take a look and then say, hey, there it is. I've taken out everything I needed to do it. And then what I'll do is I'll do a 5-0 fast absorbing to close the hemitransfixion and do a quilting stitch with a 4-0 plain gun on a Keith needle. And usually with that, that's all I need to do. You don't need to do more. Now I'm going to switch gear and do an endoscopic DCR. Can I get a bayonet? Now this is actually a technique that I didn't learn until I was teaching a course with Stamberger. And so, and then, I said, one of the easiest way to find the DCR, I would say is, can I get a freer? One of the easiest way to find the DCR is using the axilla of the middle turbinate. And so what I tell residents is the endoscopic DCR should be half above and the other half of the DCR should be below the axilla. And that's how you know where where you want to make your endoscopic dacrocystal rhinostomy. But Heinz said there's actually, if you want to double check, you can use the image guidance, and I'm going to show you the image guidance that opening that I made is where I want to make the opening is right. And so if you can show the image guidance, and you can see that I'm right at where the lacrimal sac is at right there on the image guidance. Okay. And so you can see the endoscopic view. You can see where the image guidance is, and it's telling me that that's the lacrimal sac. So if you don't have an image guidance, another way to confirm that you're in the right spot is to use a bayonet. And this is what Stamberger showed me when we were at a course together and when we were teaching at it together. He said, just use the bayonet and then use the bayonet to go to the lacrimal sac. And so where it is right here. So I'm going to use the bayonet to go to the lacrimal sac right there. I'm going to pinch that bayonet, and then you're going to be able to see exactly where the lacrimal sac is. So that's another trick that you can use if you don't have image guidance to help you confirm that you're in the right spot. So again, you know, even without that, you can see that what you want to do is make half your rhinostomy below the axilla and halfway above. Now, the way when I first started out doing these procedures, I used to make a mucosal flap, and I used to think, you know, you had to make a mucosal flap to allow it to not have stenosis. But I think that you don't necessarily need to do that. And so I already did some work ahead. And what I did is I took down the mucosa, I shaved it off. I shaved off the mucosa. I shaved the mucosa off. And then what I did after that is then you're going to see a lot of bone in this area right here. And so I used the quinoantral burr. Can I get the diamond burr? The quinoantral? No, just show, yeah. And so this is the burr that I use. And so this is a 15-degree burr. And so it's got enough of a bend. It's a diamond burr, so you can drill down that bone. So I used to use ultrasound, you know, instruments, but I realized that the diamond burr is pretty easy and it works just as well, and it's probably more efficient. So I've taken out the burr, the bone with the burr, and then the way I know that I'm in the sac is that all you have to do is press on the sac, and you should see it move right there. And there it is. And you can see that move, and that's the lacrimal sac. And then sickle knife. And so what I do is I take it, open the lacrimal sac with a sickle knife or a 12 blade. And so here's the axilla of the middle turf. You can see that the dacrocystal rhinostomy is half of it is below, half of it is above. And then all you have to do is use a sickle knife. Hey, can I get the 12 blade, the curved blade, the knife, you know, the blade that you showed me earlier, the curved one? Yeah. So I'm going to use this one instead. That the sickle knife is good, or you can use a 12 blade. And you just want to make sure you make an incision through the rhinostomy. And usually, you know, I do it for epiphora. I do it for dacrocystocele. We've done that for tumor. And what we do is you open up the sac, and usually you want to make sure you go all the way in and cut all the way through. And after you cut it in, now I used to use stents to stent it. You know, I used to do that, but now I don't stent it as much because what I could do is I could see them endoscopically and make sure that they stay open. And so that is, and then after you open through the opening, and in the cadavers, yeah, there it is. There's the opening into the sac. And then after that, then what you want to do is carefully open the lateral half of the sac, and then you want to gently take out the mucosa. And you can use through biting instruments. If you're really careful, you can use a shaver to open that up. And after you do that, what you can do is you can press on the eye, and you can see that there's fluid coming out of the eye. So I'm going to suction that just a little bit. And then, so like I said, I used to put like copper tubes in there. I don't do it anymore. If I do anything, I use the monoclinicular lacrimal tubing instead. And then, can I get the shaver? And so if you're going to use a shaver to take down the medial half of the lacrimal sac that you opened up, you want to be very careful in doing that. And you want to either use through biting instrument if you're not comfortable with the shaver. But if you do want to use the shaver, just be careful that you just take the part of it out, just the medial half of it out, and then you make the take out all the mucosal flat. So straight true cut. And so you can use a through binding instrument to cut through the mucosa. open that up, and then just make a nice opening, and then there it is. And you don't have to put a mucosal flap on there. Like I said, I used to put a lot of coffer tubes in there, but I don't need to do that anymore. And so that is the endoscopic DCR. And so I think I've run out of, I think 15 seconds. 50 seconds. All right, I got 15 seconds. All right. And so let me do a macro backbiter. So let me micro backbiter. So the way I do a maxillary antrostomy, sorry, Bert. The way I do a maxillary antrostomy, I make an incision, use the backbiter to do that, and I don't want to take away from Dr. Levine. And then by just taking down the middle half and the bottom third, that should be the ostium, and you can see the ostium right there. Use a through biting instrument to enlarge it. And then the way I do a medial maxillectomy is, can I get a freer? What I'll do is I'll make an incision through the middle turbinate here, and then through here, and then I open up the maxillary antrostomy and just take it from there all the way down. So I take down the inferior turbinate first, and then cut that, and then I take down the fontanelle wall and take it from the maxillary os all the way down, take it all the way to the medial wall, and take it all the way down, and then that's my endoscopic medial maxillectomy. And so I'll stop and let Dr. I'll take some Q&A, and so see if there's any questions that everybody has while we're switching up for the next cadaver for Dr. Levine. Any questions?
There were a few questions, actually, and one of them was, how do you identify the anterior ethmoidal artery doing the FES?
Yeah, and actually, if you asked me before we did a cadaver dissection, identify the anterior ethmoid and posterior ethmoid artery, I wouldn't have been able to give you a good answer, but that's what we did. And so when I was teaching at University of Virginia, what we did was we did a cadaver dissection, and we opened it from externally and endoscopically, and we tried to identify using the image guidance and the structures. And so now finding the anterior ethmoid artery is very easy. Now, there is some variations that you'll see based on the pneumatization of the suprabular cell, but most of the time, the anterior ethmoid artery is usually identified by finding the basal lamella. So the anterior ethmoid artery is usually about a third of the time is around the area of the ethmoid bulla, a third of the time is just a little bit in front of it, and the anterior ethmoid artery is just a third of the time is just a little bit behind the basal lamella. So it's usually around the area of the ethmoid, the basal lamella. The posterior ethmoid artery is a lot easier to find, and that's something that we need to do when you're doing an orbital apex dissection, optic nerve decompression, and even for plana meningioma endoscopic resection or craniopharyngioma resection, we find that posterior ethmoid artery. And the easiest anatomy to identify the posterior ethmoid artery is the anterior face of the sphenoid sinus. So, when you're doing that posterior ethmoidectomy, you find the anterior face, and if you go straight above, usually the posterior ethmoid artery is there. And so, what I'll do is to do an endoscopic ethmoid artery ligation. I think there's a video of it online of me doing this. Is I'll do a total ethmoidectomy. You'll take down the lamina papricia, and then you work your way forward. You know where the basal lamella is at, and then when you're pressing against the periorbita, what you see is where the artery is at. When you start pressing into the orbita, you see what I call tenting. It's a little bit of a tethered effect, and that's where the artery is at. And you have to remember that where the artery is a bundle, it's a neurovascular bundle. So you'll see a vein, you'll see an artery, and a little nerve that goes with it. And what I do is I use a bipolar, a 90-degree or 45-degree bipolar to then bipolar that artery. And it's a pretty easy procedure. The first time I did it was for epistaxis on a young teenager that wasn't getting better after SPA artery ligation. So I had to do that. And then from that, I've been doing that and it's been pretty easy. Thank you for the question.
I think Dr. Levine is ready to go. We're going to go for more questions and answers after he completes her dissection.
All right. So I'm going to start just talking about sphenopalatine artery ligation, just because we went recently from our maxillary, and it's very easy after you do a maxillary antrostomy to find that sphenopalatine artery. So we can go to the endoscopic view. And here, this is, again, the septum over here, the inferior turbinate here, the nasopharynx in the back, the eustachian tube. We've opened up into the sphenoid, and we've opened up our maxillary. So this is a nice wide maxillary antrostomy. I'm looking with a 30-degree scope, so you can see the natural ostium up here. And when you're looking for your sphenopalatine artery, you're really going to be looking at the very back, right here on that lateral wall. So here's the posterior portion of your inferior turbinate. This is just for visualization, the cut edge of that back of the middle turbinate. And so you can see this area very nicely. And a lot of times what I'll do is just raise up the mucosa. And so as we're raising that mucosa off of the bone, usually you'll see a little crista, which is that kind of pointy part. And sometimes there's a big one, and sometimes there's almost nothing. This patient has a very tiny little crista. It's just this area here. And then you can see very nicely into that sphenopalatine artery opening. And so this is your foramen. And there are different ways to do this. I frequently will have my fellows and my residents dissect just a little bit behind so that we can really see that we've gotten that whole artery exposed, sometimes a little bit above to make sure that we're not missing another branch. They always tell you that there's only one branch, but I can definitely tell you that there are points where there are multiple branches. I'll take a upkerison, a small one. And so a lot of times here you can clip this artery. And so one way, if you have endoscopic clips, is just to clip it here. Another way is going to be to cauterize it. I usually like to actually get my kerison right into this opening and just take a little bit of that bone. And the reason I do that is so that I get a better visualization. I'm able to really check and be sure that there's not going to be another branch there. And so I'll just do a couple little bites to give you guys a good idea. Obviously, if you kept following that for certain types of pathologies back, you can then trace out your IMAX. So that's another way to do that. But here you can see that we take out just that little pieces of bone. And now you've got a really great view all the way around of this opening. And I think that that allows you to be sure that when you're going to clip it or you're going to cauterize it, you can get the entirety of it. I don't have any endoscopic clips that I'll show you here, but I will tell you that a lot of times people will cauterize this with a suction bovie. I have stopped doing that because of the proximity to the other arteries and all the nerves. And so a lot of times I'll actually do it with a bipolar. So here is our kind of mock bipolar here, and I can then bipolar this area, and I haven't had anybody come back with any numbness. So that's been great. So this is how you would do your sphenopalatine artery ligation. So then the next thing that I'll talk a little bit about is going to be going to do our frontal. And I think this is probably a good time to show both our navigation as well as the endoscopic view side by side, just so that I can show you the anatomy in this particular cadaver. So if you look here at the anatomy in this patient, you can see that they've got some complex frontal anatomy. I believe that you're seeing all this on the coronal view, and you can see that there is a cell that's contained within this frontal sinus. So I think Dr. Wormald talked a lot about the complexity sometimes of frontal sinus openings. And so it's good for you to know and be familiar with that anatomy. And then you can see on the other side, there's a little osteoma there. You can also see some different cells contained within the frontal. So this is a well-pneumatized frontal. I have the middle turbinate here, if you can see on the endoscopic view, that I've left intact. I've opened up the maxillary. We've taken out a portion of that uncinate. We've done a lot of our ethmoidectomy here. This is going to be where that artery is. So there was someone who was asking about identifying the artery. We can see it here, and it's been nicely shown because this has been an injected cadaver. And so then you can see with the probe that we're able to see into where our frontal is going to be. We can also see these different cells that we were talking about here under the axilla of the middle turbinate. So a lot of times you want to be able to have that frontal process, your middle turbinate here, And then now that you know that your anterior ethmoid artery is here, you know that your opening is going to be anterior to that. You want to have your auger open. And then a lot of times with your probe, especially in a cadaver where all the bone breaks up very easily, you can look. Now this is a 30-degree scope. A lot of times when I do my frontal, I actually will do it with a 70, and we'll switch to that in a second, but I wanted you to get to see what you see with a 30. And also that sometimes you can't see everything. So you can see where we are with our nav. This is just doing everything with the probe, breaking it up. And you can see that we can see up into that frontal. So now I'm going to switch to the 70-degree scope and just show you a very different view when you use a 70-degree scope. And a lot of times I'll use a 70-degree scope when I'm doing anterior ethmoids, and I will also use a 70-degree scope when I'm doing the frontal. There are a lot of different ways to do this. You'll find people that do everything with a 30. You'll find people that do everything with a 70, but you'll see that there's a very different view. So here is our 70-degree scope. Just make sure we're fully focused here. And now you've got a very different view of all of this anatomy. It's just a very different way to look at it. And I find it very helpful. One thing to remember when you have a 70-degree scope is that you want to be cognizant that you're going to be looking more back at yourself, if that makes sense. So when that happens, you need to actually put your scope in a little bit further. So this is part of that training process. So before I start taking out all the bone, I just want to show you that now with the 70, you can see a little bit better that anatomy. So you can see what we were seeing before here. And you can also see that now here we're getting into that other area of the frontal. So it makes it a lot easier to be able to see the rest of that area. And you can see my probe. Now we're up into that very large frontal cell. So I'm just going to take a little bit of this out. We'll use one of the cobras, which is one of the instruments that was being talked about before in the lecture. And these are nice instruments because I kind of bite back on themselves. A lot of times when I teach my residents and my fellows, I like to teach them to do as much as they can with non-powered instrumentation. And so here we're just very easily, because we can see behind each of these things, we can break up all of this bone and this soft tissue. There are a couple different ways to take all of that out. Sometimes you can take it out just with your instruments. You can pull it out. But if you're trying to preserve mucosa, a lot of times you want to be thinking about ways to keep the mucosa there. For time, I'm going to do this a little bit faster than I usually would if I were doing it in a person who's awake. But this way, you get to be able to see that process of breaking it up. We can also do it with a curved microdebrider. So we'll have them put on the curved microdebrider, and then we'll be able to show you that as well. So this is moving into the realm of doing a draft 2A. So now we're opening up everything between the lamina. And I'll push on the eye in a second. But we're over into the lamina, and then we're up into our frontal, and we're getting into where we can see also in relationship to our middle turbinate. Now, if we wanted to do a draft 2B, that would take us from lamina into the area of the septum. And so first, I'll show you removing a little bit of that tissue. This is a 60-degree microdebrider blade. These are not navigated, so you do need to make sure that you see what you want to see. I will often have the blade open facing forward so that I'm just debulking the tissue that falls into it. I'm not dissecting with that. And so now you've got this nice view up here, and you can kind of see into these different spaces with the cells. And I'll go back to my navigation probe just to show you that. And then I will take a straight through cut, and I'm actually going to take down a portion of my middle turbinate so you can see where we are in relationship with the cell that's here, and then going over into that more medial portion. All right. So now if you take down a portion of that middle turbinate, you can do a draft 2B. This is something that is worth doing for a patient where perhaps their anterior posterior diameter, as discussed previously, is not as large. And so you need to get additional space. Sometimes you're doing this because you have anatomic reasons that you need to be able to access something laterally and you don't want to have to do a draft 3. and you're able to just get it out with a draft 2B. And a lot of times I'll just take off the head and a little bit of that anterior portion of the middle turbinate. Here you can see with the latex injection, it's a little bit kind of chewy. But this gives you a nice opening. I'll take that through cut back. Thank you. And so you've got a little bit better view. And then I will take the cobra. I'll just talk a little bit about taking off some of the frontal beak and also doing our superior septectomy. And then I'll show you a completed draft 2B on the other side for the sake of time. And that way we can focus on our Lothrop. So I do think that cobras or Hosmans, or in my case, I often use a curved kerrison, are very helpful for the frontal and a lot of the frontal work. You've got some really hard bone there. You want to be able to take all of this stuff off. And it allows you to really bite through a lot of that bone and move quickly and give yourself a little bit of space so that if you are going to drill, you're farther away from the back wall of the frontal. And I think that that part is really important because you want to be safe when you're doing all of this. So this is your axilla of the middle turbinate. We've taken down a lot of that, and you can continue to take that down with a drill. And so this gives you a nice opening here so that you really can start that process of doing a bigger draft 2B by drilling everything over. The last thing that I'll show you as far as a completed draft 2B is on the other side. So over here again with the nav probe. On this side, you can see that maxillary antrostomy. We completed our anterior ethmoidectomy, and now we're up to our draft 2B here. And so I can have the probe in just so that you're able to see that area. I did take out that small osteoma that was already there, so that's been removed. We're right on our septum here. You can be back onto the cribriform, and we're all the way drilled anterior. So now I'm on the anterior wall. I think that that gives you a really nice view. You can see over laterally and a little bit over medially. And so this is a nice opening for a draft 2B. You can see how large that area is, how much space that you have. And then if you wanted to convert that to say that's not big enough, or that you need to get all the way over lateral on the contralateral side, then you can convert it into a Lothrop. And one of the things that I always got taught that I liked very much is that if you put your frontal probe sitting on the back wall of the of the frontal sinus, anything above that probe is what you can take out for your septectomy. And so that will be your superior septectomy. There are lots of different ways to do that. In a cadaver, it's very easy to kind of break through here. Sometimes in someone that has really hard bone, I'll actually cut a little flap here, flop it down, and then push it back over at the end of my superior septectomy. In this case, for the sake of kind of time and ease, I'm just going to go right through this. I'll take a straight through cut in a second. But this really allows you to get a good view. And what you'll see then is your view of the frontal sinus on the other side where I haven't drilled anything. And you'll see the frontal sinus on this side where I've really opened it widely. And I think it's important to remember that when you do frontal sinus surgery, a lot of times your natural ostium and your entry is not at the front of the frontal sinus, it's actually closer to the back. And so that tells you a little bit about where you're entering. I'll take an upbiting through cut. The superior septectomy is always one that you adjust according to the patient. Patient's anatomy is a little bit different. You obviously want to protect your olfaction. You want to give yourself a good view. I'll take the microdebrider next. And you don't want to do a huge septectomy because you don't want to destabilize anybody. So you always want to be very thoughtful about that part of the process. And I think this is the piece that frequently my fellows get stuck on, is just how to see where they're going, doing their superior septectomy. And that's why I think that frontal sinus probe technique makes a big difference. So this gives you a view now over where you can see your frontal sinus on the other side, right here. And you can see how much space you have on one side versus the other. All right. So I'm going to take the burr. I'm going to take a 70-degree diamond burr. And I'm just going to show you a little bit of drilling to connect this quickly. And then we can move forward. But I do think that this It gives you a nice view, and you can see that you'll be able to work a little bit from both sides. Excellent, thank you. I often will use a 70-degree diamond to start, or when I'm training my fellows, or if I'm near the eye, and then frequently I'll switch over to a cutting. So this is a 30K burr. You can see that it goes through the bone very quickly. I always teach my fellows to go forward. Forward is always safe. You're going anterior, away from the brain. And if you're in this view, you're also away from your eye because you can see where your orbit is over here. So I think that that helps a lot with that process. I always teach that you want to come as far forward as you can and then cross, because remember that your cribriform is going to be jutting out at you. I'm looking with a 70-degree scope, and so because it's jutting out at you, you don't want to cross in the back here. You'll end up in your cribriform. You want to cross further in the front. So I'm just going to cross this over a little bit.
Notice that she's doing a horseshoe shape of that. She's modeling that horseshoe shape of the frontal.
She's working, but... And I apologize. We're having a very real world problem where the suction on the burr sometimes gets a little bit clogged. And just for the sake of time, I'm going to do this a little bit faster, just to try to make up some of our time. But I'll show you that we're on our anterior wall in 1 second. Thanks for... I can switch to a cutting. So you can see now I'm nicely into my frontal here. I'm into those 2 different cells, and I just have this little area to cross over.
And she's drilling into the beak area of the frontal.
And so this will be where your cribriform is going to sit. This is the back wall of your frontal. And then we'll eventually get a curved section, and I'll show you the rest of that. Thank you. So you'll see that the cutting burr goes through a little bit faster. One of the reasons why they're nice to use, but they also can be a little bit more dangerous. So you want to be very thoughtful about where you're going quickly. In this case, because we're centrally located, we're going anterior, we can see all of our anatomy. This is a safe case to do that. I also know that we talked at one point in one of the lectures about preservation of mucosa. It's really ideal when you're just doing this for sinus disease, if you can, to preserve the back wall mucosa so that you're only drilling anteriorly. I'll take a straight through cell. And then here you'll be able to see that we have crossed over pretty quickly. You can put out some of this extra mucosa here just to get that out of your way. I'll take the cobra in a second. And so you can see that now we're connected here on both sides. And we have a curved section of this. And then when you're doing your Lothrop, you can always go further forward. You want to be able to take down as much of this beak to get yourself a good view. And a lot of times at the end, which I won't do now, you can polish all of the bone so that it just is a little bit smoother. So here you can see that different cell, that type 4 cell. We'll actually be able to take that out if we keep going. But you want to know that you've gotten into all of those areas. So I'll show you with a frontal probe, and then I'll quickly show you an orbital decompression, and then we can move forward. All right, so if we can show both the navigation and the endoscopic view. So now you're seeing your back wall here. You're seeing your anterior wall. We're seeing that contained cell, which you can see that I would be able to take out. And you can also then access more laterally over to the side on each side of your funnel. So this is your nice Lothrop, and this is your first, if you push this mucosa back, your first olfactory filly here. So we've been able to preserve our cripiform. So the last thing that I'm going to show you is going to be an orbital decompression. I'll go back to the 30-degree scope just to have a little bit more kind of consistent view that I think most people will do it with. Very few people do an orbital decompression with a 70, although it's certainly been known to be done. And over here, again, inferior turbinate, septum, maxillary, sphenoid back here. We have our frontal up here if we look up. So at the side, this is all our orbit. Obviously, within a cadaver, those tissues are a little bit different. It's in a regular patient, it's usually not quite as compressible, or it certainly can be. I will frequently try to enter a little bit low and medial, using often a freer or a caudal to get through that lamina. Here, a lot of that lamina is actually already kind of broken up. So you can see that I'm on periorbita here already. And here I'm taking off just those little pieces of bone. I think that this is one of the safer ways to do this. Sometimes when it's very firm and very hard, I can use a kerrison as I go up to take off the rest of the bone. But here, as you take off that lamina, you want to keep in mind the view that you have, which is a great view here. And so if I to push on the eye, and remember, you won't see quite as much movement in a cadaver, but you can still see that you're near your orbital fat, that the periorbita that is still intact from the preservation is visible. And then this is where you would see your anterior ethmoid artery as well. And you can see that coming out of this area of the orbit. I'll just dissect that off a little bit. And so if you needed to clip that or to get access to that, this is the area where you're going to see that coming from. So I will take any questions either for myself or for Dr. Hahn, and we'll turn it back over to our panel to let us know what we can answer for you.
That was fantastic, Dr. Levine. And I'm surprised you were able to do all that in 19 minutes.
Little faith.
So, Dr. Chris,
Can you
or
hear
Dr.
us?
Sullivan?
Can you hear us there?
Yes.
Yep.
Okay, yeah, I thought we lost the audio. Okay. Dr. Crespo, you have a few questions there.
Yes, so there's some questions from our Q&A tab. We have a question from Atanasio Claude. How far anterior to the axilla you make the incision for the decurial? How many millimeters? I'm guessing the question is.
I'm sorry.
How far anterior to the axilla of the middle
axilla
turbinate
will you
you
make
make the
your-
incision?
Oh, so I usually make it until it goes to the anterior part of the lacrimal sac. And so I go as far anterior as possible. And kind of like the Lothrop, there will be some stenosis. So you want to make it as wide and big as possible. So, and when you do the endoscopic DCR, you can clearly see where that anterior part of the lacrimal sac is at. So you want to take it as far as possible.
Yeah, it's nice to decompress the whole thing. And as was nicely pointed out by Dr. Hahn, you really want to kind of marsupialize and remove that entire medial aspect. That way, it's very hard for it to restenose. And you want to make sure that that area stays open. Usually I'll put some dissolvable packing over that area just to make sure that it does not stenose closed with any scarring.
Actually, that's one of the questions that we also have from the Q&A. If you, what type of packing do you use after frontal sinus, well, any sinus surgery?
Oh,
There's lots of options. I don't know that there's one that's better. I usually will use dissolvable packing. I like to put steroid and antibiotic in it. I really feel that that makes a difference for a lot of my patients. I am a big fan of kind of all of the dissolvable packing. I've used almost all the companies. I don't know that I have necessarily a big preference, but I do think that it makes a difference. I was a late converter on that. And I think that the scarring and the healing is so much better, and it helps with pain control by having a steroid there.
yeah, and and PJ kind of talked about this a little bit earlier. Dr. Wormald talked about this a little earlier, where he talked about sometimes people use like silastic splints to keep the Lothrop open, but now we've been using these steroid implants, and they're specifically designed for the frontal sinus, and Medtronic sells it. It's called Mini Propel, and so that's what I've been using. But if that's not available, certainly a dissolvable packing with steroid is good. And not to promote what Dr. Wormald has, but he has this thing called Kyta gel that I've been also putting Kenalog in there and using that as another option for dissolvable packing.
Unfortunately, we're out of time. I want to thank our speakers. Great lab session for the first. I appreciate you traveling all the way to Jacksonville to do this, and we appreciate it very much. Remember, we're going to be emailing the link to the video of the presentations in the next few weeks. And I will now turn the program back to Dr. Maria Zurna, our coordinator for international affairs.
Thank you.
Thank you so much. Thank you to all of the participants for joining our global grand rounds. I really appreciate all of the panelists and moderators for doing a wonderful job. This was our very first live cadaver dissection, which I think went fantastic. So thank you, Dr. Han and Dr. Levine, for doing such a wonderful job. And of course, thank you, Medtronic sponsor, for letting us use the cadaver lab and supporting it. I think this was very valuable experience for people all around the world, and we really, really appreciate it. Please save the date for our next global grand rounds. It's going to be in July 26th, the same time. It's going to be on management strategies for chronic otitis media. And it's in collaboration with the Confederation of European Otolaryngology Head and Neck Surgery and African Otologic Society. And we're looking forward to this next wonderful event. I also want to remind you that annual meeting of the Academy of American Academy of Otolaryngology Head and Neck Surgery is going to be in Indianapolis, Indiana. And again, this is going to be an opportunity for people to network and learn. So please remember to register and attend. It's always a wonderful event. So looking forward to seeing everyone there. As a reminder, application for some of the educational funds are approaching. It's April 14th. If anybody wants to apply, please hurry up and submit the applications. Eugene Myers's Global Fund, Educational Fund helps otolaryngologists who are fully employed and practice in low-income countries and with low resources to attend American Academy of Otolaryngology Head and Neck meeting, and also some associated events. And again, the deadline is approaching, and you can look at the Academy's website for more information and for application details. We also have a program for international visiting scholars. This is for young physicians under 40 years of age. Again, preferences will be given to people from low-income countries. And again, the application deadline is approaching April 14th. So please go to the entnet.org/IVS to find out more information and submit the application. We have discounted rates currently for international members, so please take advantage of that. That gives you wonderful opportunities like educational opportunities, opportunities to participate in various events, grants, scholarships, and other resources. And again, we also have more discounted rates for people from lower income countries as well. So again, time is limited, so please join, and we look forward to having more international members partake in our global society. And again, thank you. Again, thank you everybody for a wonderful event of wonderful global grand rounds. And if you have any further questions, please feel free to contact us. We're looking forward to further collaborations with everybody. And again, if you saw in the charts, there's been really global participation in this event. And again, thank you so much to the panelists, moderators, American Academy, our sponsor, and again, see you soon. Thank you.